First, I'd like to say thank you, Dr. Morante, for helping me pass the ANCC exam. I did take the Flex crash course. I did the question banks, and the one-on-one was super helpful, especially with the fast facts that were provided. I'd like to thank you, Dr. Morante, for being such a supportive preceptor and mentor throughout my process. Your knowledge and experience and compassion are top-notch, and I'd recommend you to anybody. So again, Dr. Morante, thank you so much for being so supportive, and I am thankful that you were my preceptor, and the classes that you provided were very informative and really helped me to pass the test. So I just wanted to say thank you.
Hi everyone, my name is Mary Janica Tan, and by the grace of God, I just recently passed my NCLEX. It still feels unbelievable to say that I am now officially a registered nurse. And I did it with the help of a very brilliant tutor, Dr. Peter Morante. I started as a negative thinker who was full of fear, but then I changed my attitude about it, and I enrolled to his NCLEX bootcamp, and Dr. Morante trained me to stay positive, to work hard, make it happen, and get that yes, yes, yes. So with the training and resources he will provide, you'll be golden. But of course, you have to do your duty to study and manage your time. Surround yourself with a good support system and study smart with Morante Associates. Combine it with a positive mindset, and you'll achieve anything you set your sights on. If I can do it, you can do it too. Good luck.
And I just wanted to share how grateful I am that I joined Dr. Peter Morante and Associates NCLEX Bootcamp. I wouldn't have achieved my goals without them. Their tools were really useful. That includes the Zoom classes, the PowerPoint, and testing strategies, Kahoot, assessments. So I utilized them all and passed the NCLEX. And I think I joined like 11 or 13 sessions, including the last one that I still attended the day before my NCLEX. We also did a lot of Kahoot questions, which was really challenging but also helpful because it was quite similar to the actual NCLEX exam. It was short and vague. So yeah, overall, I just wanted to thank Morante and Associates for everything. And if you're looking for a solid and a really good NCLEX review, go for Morante and Associates. You won't regret it.
Proud of you. Okay. And you finished the exam in 25 minutes? Oh my God.
Yes, yeah.
It means you're doing it correctly. That's the reason. I did it really well. Proud of you. Okay.
Thank you.
Great. You passed the board. Ready to roll and be one of the best nurse. Happy Nurses Week to us, right?
Yes.
I'll have some good time with you. How many questions did you?
I got 85.
85?
And
Then
closed
you're
out.
smart. That's the minimum.
Yeah.
Okay.
Di ko alam kung pumasa ako eh. Tapos the next day I got the email.
I got
Malamit,
the
like, I didn't even know I passed. The school emailed me first. And they're like,
Oh, the school know already?
Yeah.
Welcome. Congratulations on passing your NCLEX, Marisa Franco, right?
Yes.
How was the NCLEX experience? Was it so easy for you?
It wasn't bad.
Any advice that you want to give our BSN students or anybody that will pass the NCLEX?
I think it's learning how to answer NCLEX style questions. I feel like throughout nursing school, everything was more not textbook based, but more science based. And then when it came to NCLEX, it was strictly safety and knowing what they're asking. It was like a completely different style, but learning how to manage those. And then case studies, it was a pretty huge chunk of it. Every case study was around 6 questions, I think. So really taking your time with those and knowing what they're asking you. If you're not sure, don't pick it. If you're second guessing between two, which one sounds safer? And if you have no idea what they're asking you, come up with your best educated guess.
You ace it. I'm so proud of you. And now you're going to be doing your PULS, ACLS, and BLS and be spreading your wings to become one of the rock star bedside nurses. Am I correct?
Yes.
I'm so proud of you. I guess we're live again. And welcome for another episode and another edition of NCLEX Lock It In Live. Yesterday, Professor Letty was able to go live for the PMHNP version. Now I'm coming up with your NCLEX Lock It In Live, and I hope you guys are enjoying what you guys are getting from our review center. So my name is Pedro Morante. I'm the founder and also an exam strategist of Pass Review Center. And today we're tackling one of the most tested and most intimidating topics on the NCLEX Next Generation for both the practical nursing or your LVN and registered nursing next generation exam, obstetric nursing. So if the words of preeclampsia, placenta previa, fetal heart rate, or postpartum hemorrhage make you so nervous, you are not alone. And I was once on your shoes, guys. I was testing for this exam and basically got intimidated by these different terminologies. But here's the good news for today. The next gen NCLEX isn't looking for an obstetric specialist. So they don't want you to become an OB specialist, but it's looking for a safe nurse. So what does it mean by that? Safety entry level nursing. So whether you're taking the NCLEX PN and NCLEX RN, you'll be expected to recognize life threatening maternal and fetal emergencies, prioritize the most urgent patient, and make safe clinical decisions under pressure. So today's session isn't about memorizing dozens of pregnancy disorders. It's about learning how to recognize the red flags that the NCLEX wants you to catch. So we'll walk through real life, next gen style questions, and together we will do a practice clinical judgment, eliminate distractors, and most importantly, learn how to think like the NCLEX. So you gotta be test mode ready. So by the end of today's session, you'll recognize the difference between placenta previa, placental abruption, or abruptia placenta, know when magnesium sulfate can save life or become life threatening, or identify fetal heart rate emergencies, and confidently prioritize the safest nursing intervention. So I would like to ask everybody to at least grab your notebook right now, answer the questions with me, and don't worry. If you get one wrong, that's how we learn, because every question we answer today brings you one step closer to hearing the words, "Congratulations, you passed your NCLEX." So let's lock it in. And that's basically going to be focusing on your health promotion and maintenance, which is 6 to 12% of your exam for the RN exam, while 6 to 12% also in your health promotion and maintenance for your NCLEX PN or NCLEX LVN. So, what are the high yield OB topics that we can go over? It could be a prenatal care, right? Fetal development, labor stages, postpartum care, newborn care. And then, according to the current test plan, physiological adaptation is big on your RN exam. So, 11 to 17% on your physiological adaptation for RN, and then 7 to 13% covering your physiological adaptation for your LVN or NCLEX PN. And then we're going to talk about preeclampsia, eclampsia, HELP syndrome, postpartum hemorrhage, placental disorders, and obstetric emergencies. And then reduction of risk potential for RN covers 9 to 15%. And then the same thing with your NCLEX PN, 9 to 15%. So we're going to talk about fetal heart interpretation there, complications of labor, maternal assessment, magnesium sulfate monitoring, and of course, the most favorite, very important, our bread and butter pharmacological therapies, 13 to 19% in your RN exam, and then 10 to 16% in your PN exam. So, what does it cover? Your function of your oxytocin, magnesium sulfate, your ROGAM, your antenatal medications, or your uterotonics. So before we begin, we have a simple one rule here, right? Every NCLEX question that we are asking you right now is you need to make sure to remember who is in the greatest danger right now when you do your prioritization. If you can answer that OB question, you'll answer the most OB questions correctly. So let's start with that. So once again, if you are tuning in for the first time here, we are doing a rapid review of your obstetric nursing. So we're gonna give you strategies and gonna give you main focus is to analyze the question, assess, and of course remove distractors. All right. So once again, our new website is officially launching and it's actually live right now. So if you guys are tuning in, you guys can go to our website www.passnp.com. So you scan the QR code in front of your screen, and then you'll be able to get some questions there for free. So what I'm telling you is that we are giving you guys tools that you guys can use for your board examination. So we prepared exam questions that can mirror the actual blueprint of the NCLEX and also your PMHNP, FNP. And a lot of this will be on that platform. So if you're not part of our community, I would like you guys to subscribe and then sign up and access it for free. So there's no credit card that is needed. We just needed some of your information so you guys can access the platform, which is your email and full name. Okay. So once again, this is a platform that you can study smarter and then you can be able to practice the question banks. And we're fully launching a video question banks. So what does it mean by that? A real coach that tells you why not A, why not B, why not C, and why not D. So a lot of board preparation exam questions are just cut and dry. They're gonna give you a question and they're gonna give you a rationale. So one thing that will stand out in this platform is that you will recognize we have video, question banks, and rationals. So we put our time and effort, guys, in putting you guys the best board preparation that you guys can experience in our question banks. So try it for free. There's no harm in trying. And if you are not testing yet, you can share it to your PMHNP bestie or NCLEX bestie or anybody who is testing for your exam. So one help or one message to your friend can change their life. So I want you guys to be an instrument for that. So once again, it's www.passnp.com. All right. So we'll start with OB questions. So these are things that we're focusing on today, right? Preeclampsia, eclampsia. So what's the difference, right? So if somebody had a seizure already, does that falls into preeclampsia or eclampsia? And if a patient is experiencing seizure, should we leave the patient alone? And that's a very big safety questions that we need to make sure to prioritize. Never ever leave your patient alone, right? Especially if they're in active seizure or they have eclampsia. Okay, and then we also have your HELP syndrome, which we're going to talk about. Your magnesium sulfate toxicity. Now remember this with the mnemonics of BURP. So what is BURP? We're checking for blood pressure because they can drop blood pressure. We're checking for the letter U, urinary output, which they can have oliguria or scanty urination, and they can have letter R, respiratory rate that could be low also. And then letter P, which stands for patellar reflex, which is down. So just think about that one. When there's toxicity for magnesium sulfate, and you're the registered nurse taking care of this patient, you gotta monitor those blood pressure, urinary output, respiratory rate, and patellar reflex. And then making sure that there's an antidote on the bedside where we're in it's called calcium gluconate. So I want you guys to remember calcium gluconate, which is the antidote for your magnesium sulfate toxicity. And then fetal heart rate patterns. So I remember that as VL chops. Variable is what? Variable early acceleration is okay, and late is placental insufficiency. So V stands for variable. So that will be your cord compression. Letter E stands for early deceleration, and that will be your head compression. Letter A stands for acceleration is always okay. And letter P is placental insufficiency. So that will be for your late deceleration. So we will go over that. And then make sure, guys, you guys know the difference between placenta previa and abruptia placenta. So which one is dark red, which one is bright red. So they're opposite, right? So which one is painless bleeding, which one is painful bleeding, which one is soft abdomen, which one is board-like abdomen. So as you can see, you have to have a good understanding of which characteristics falls into the placenta previa and which characteristics fall into abruptia placenta. And then you have your postpartum hemorrhage, right? The classical symptoms of hypotachytachy, hypotension, tachycardia, and tachypnea, and of course your oliguria. So we're going to talk about that. Shoulder dystocia and cord prolapse. And then of course your selectal apply, SADA, which a lot of students says, oh my God, it's another selectal apply. Then that's something that we need to work on to choose only the options that are applicable to the question. And then you have your prioritization. So who will you prioritize? Somebody who has um, complexity in terms of their pregnancy, or somebody who has a simple, straightforward pregnancy. Of course, we're looking at somebody who has more capability to die, which could be in the form of disseminated intravascular coagulation, wherein they bleed and they clot and they clot and they bleed out. Or it's probably somebody who needs to be delivered forceps delivery. They have multiple parity, so we're going to talk about that. And then very important is your NGN case studies. So once again, it's not enough you know placenta previa, you know abruptia placenta, or you know fetal heart rate patterns. Remember your VL CHOP as mnemonics, or you know magnesium sulfate toxicity. They're gonna present that in a scenario question, and you are the registered nurse or you're the nurse taking care of that patient. So every second counts. When we what we do we mean by that is that we need to make sure that we are addressing the needs of the patient when we're testing for this exam, because they're all about safety and competence. Next, your best priority formula. So, letter P stands for protecting the mother and the fetus. This is very important, guys, when you're testing for the board exam. Remember, in one body, there's a fetus. So, what does it mean by that? In one body, you have two clients already. But what about if they have twins, or they have triplets, right? Or they have eight babies, optimum. That happens before. And one thing that we're making sure is that there's no fetal hypoxia, there's no maternal hypoxia, and we need to make sure that the mom and the baby is in homeostasis in order for you to have a smooth delivery. But when there's hindrances, like they either have supine hypotension, maternal hypoxia, maternal bleeding, and that's where it poses a threat also for the fetus or for the baby. So you need to make sure you're good at that. And then letter A, assess the danger pattern. So what are the danger pattern for your patients? Could be they're bleeding, but also it could be experiencing late deceleration, and then what else they could be experiencing like chest pain, wherein it could be classical symptoms of pulmonary embolism too. And then stop the cause. What does it mean by that? You really need to stop the offending agent, or you really need to identify is this really magnesium sulfate toxicity, or that's you need to give a calcium gluconate, or something that we need to prioritize is to making sure that we identify the cause or etiology, and then call the physician or your women's health nurse practitioner on, or the residents. Then support and escalate. It's very important that we're providing enough support for our patients, and therapeutic communication from us. And then recognize the emergency and choose the safest first action. So what do you mean by that one? Assessment, making sure the patient is safe, making sure that if they're experiencing maternal hypotension, put them to the left. Remember the song of Beyonce, right? To the left, everything you own backs to the left. So you have to make sure you put them on the left lateral position, not on the right lateral position, because this is where superior and inferior vena cava is located, and what's going to happen is they have more compression of it, leading into supine maternal hypotension, okay, or your vena cava syndrome. And then making sure safest action. So I guess everybody's ready for the question for today, okay? And we'll start. So this is your unfolding case study, and we're gonna talk about severe preeclampsia. Okay. So you have a patient that is a 28-year-old client, gravida 2, para 1, is admitted at 36 weeks and 4 days of gestation. So the nurses reports, they report about severe headache for 3 hours, and they state that the lights look like they have spots around them. They report right upper quadrant abdominal pain, and they have facial and hand edema that is noted. Then their deep tendon reflex is 3 plus, and then there's 2 beats of ankle clonus or plus 2, and then fetal movement is still present. Now, if we look at the vital signs of the patient, remember there's a chevron there that you need to click, and it will reveal the information. Then we're looking for vital signs. The findings are as follows. Blood pressure is 168 over 112 millimeter mercury. Heart rate is 92 beats per minute, and respiratory rate is 18 beats per minute, or 18 per minute. And then oxygen saturation is 98% in room air. The temperature is 37 degrees Celsius and 98.6 Fahrenheit. Now, the lab results, we have results for your platelet count, 88,000 per cubic millimeter. Then you have your AST and ALT, your liver function tests. And then your serum creatinine, 1.3 milligrams per deciliter. And urine protein to creatinine ratio, which is zero point 0.6. Okay, so once again, we're talking about severe preeclampsia. So the main differentiation between preeclampsia and eclampsia is the presence of seizure, right? So if a patient undergoes seizure or active seizure, then we don't call it preeclampsia anymore. We call it eclamptic or eclampsia. So remember that patient needs to be monitored for both. Never ever leave your patient alone. So recognize the signs and act without delay. And that's pretty much important that we need to remember. Okay. So let's talk about this case scenario together. Do not answer yet. First, highlight the danger words, right? What do you see? The blood pressure is 168 over 112. That means that's severe hypertension. They have clonus, they have neurologic irritation, and then the platelets is 88,000. That's pretty low, right? Very low. That's a red flag sign too. And then they have a right upper quadrant pain and visual disturbances. Now ask yourself, what story are these clues telling you? Is this patient stable or unstable? And is the patient progressing towards severe preeclampsia with what syndrome? So go ahead, put the SARA answers in the chat box for those who are tuning in again. Which findings requires the nurse immediate attention? So select all that apply. Letter A, blood pressure of 168 over 112 millimeter mercury. Letter B, 2 beats of ankle clons. Letter C, platelet count of 88,000 per cubic millimeter. Letter D, fetal movement that is present. Letter E, right upper quadrant pain. Letter F, heart rate of 92 per minute and visual disturbances. So for those who are tuning in right now and you're joining through our live review, Okay, from the Philippines, from India, UK, US, from different standard time zones. So please make sure to type in your answer into the chat box and do not be afraid to answer correctly or incorrectly. That's why we're here, going to coach you how to think about this and make sure you guys recognize this syndrome. Okay, so I'm going to give you some time for us to answer this question. So type in your answers, guys, into the chat box. All right, so I guess everybody's trying to answer. And for those who are tuning in once again, welcome. If you have a friend that will be taking their exam, please have them follow us and also make sure that we have free lab classes that will be benefit for them. Okay. All right. Clarice Baloyet says, "Hi, sir. Are you accepting consultant or mentor for NCLEX as part time?" Wow. Okay. Yes, I established this review center last 2015. We can definitely talk about it, Ms. Cherise. Just shoot us a message or email us. But we'll definitely gonna collaborate. We're open for collaboration, guys. Okay. So Georgina says A B C E G. Charles Dulay says A B C E G. Thank you. All right. Thank you for answering. Okay. So let's look at the question. Remember, we talk about the blood pressure so high. 168 over 112 is something that is red flag, and we need to make sure that elevation with the blood pressure means a significant increase for risk of stroke and placental complications. So letter A is definitely correct. Now, letter B, clonus, indicates central nervous system irritability, and that also increases our risk for seizure. And that's what you're leading towards eclamptic episodes, which could be a HELP syndrome. And letter C stands for thrombocytopenia. So if we break it down, thrombo means clot, cyto means cell, penia means deficiency of. So thrombocytopenia suggests worsening disease and possible HELP syndrome. Okay. And then your right upper quadrant or epigastric pain may indicate liver involvement. And that's the reason why we're adding that. So anybody who has a liver problem or liver damage, we're focusing on them being jaundice, right upper quadrant pain. What else? They have a pink tinge urine. And then what else? If they're dark skin, guys, you need to check their palms. You need to check their oral mucosa, buccal mucosa. And also, of course, you need to check their sclera. So make sure, guys, remember those. If you are dark skinned, then you have to make sure or your patient is dark skinned, check on those areas because jaundice may not be visible on the other parts. Okay, and then we have your visual disturbances. As we know, visual disturbances are severe neurological manifestation. So they will tell you they are seeing halo lights, or they are, and that could be an aura of incoming seizure. So make sure, guys, remember your alpha, beta, Charlie, echo, and then of course your Georgia as answers. So fetal movement and maternal heart rate of 92 per minute are not currently abnormal. So what does it mean by that? You have to group the symptoms. So these symptoms go in this section, and then the good signs go in this section so that you can best answer them correctly. So once again, make sure guys know your alpha, beta, Charlie, echo, and Georgia symptoms. Okay, very good, everyone. And then why the others are wrong. And one thing that you guys can benefit from our program, if you guys join our program and it's free. Remember, once again, it's free for everybody as long as you're part of our community. Letter D stands for fetal movement present, and this is a reassuring and not an immediate danger sign. So, what does it mean by that? When there's acceleration, it is okay. When there's late deceleration, it's placental insufficiency. When there's variable deceleration, then that means there is cord compression. When there's head compression, then that means there there could be head compression. So remember that VL chop. B is letter C, variable is cord compression. And then letter E, early deceleration is letter H, head compression. Acceleration with the letter A is okay. And then letter P is placental insufficiency for late deceleration. So remember your LP, and then your V variable is cord compression. Early is your head compression, and then your acceleration is okay. And the letter P, placental insufficiency, is late deceleration. So remember those, okay? Everybody good? And then D and F are incorrect. So think about your HELP syndrome, right? So looking at head, if they have severe headache, they have eye problem, blurring of vision or spots, they have liver damage, right upper quadrant or epigastric pain, or letter P stands for pressure, blood pressure of at least 160 over 110. So you have your hemolysis, elevation of your liver enzymes, and also your low platelet. That's why it's called HELP. All right, just drink water real quick. Mhm. And everybody got it correct. Very good. So once again, the next scenario is, which condition is the nurse most concerned that the client is developing? And I think we answered this correctly. Is it acute fatty liver of pregnancy? Is it letter B, HELP syndrome? Is it letter C, placenta previa? Or is it letter D, gestational hypertension? So alpha, beta Charlie, or delta. Okay. Make sure you guys are good with recognizing symptoms, and we need to make sure we recognize the distractors. You guys good so far? Georgina answered letter B. How about the rest? Make sure you're typing it into the chat box, letter B with a question mark. Remember your HELP syndrome. What does it mean? There's hemolysis, there's elevation of liver enzymes, and there's also low platelet counts. And that basically your HELP syndrome. So it's not an acute liver or cirrhosis. So remember your patient with elevation of their AST and ALT. They have thrombocytopenia on the scenario. They have right upper quadrant pain and severe hypertension, headache, and visual disturbance. These are red flag symptoms. And then remember your gestational hypertension does not include severe end organ manifestation. Your placenta previa, it has painless vaginal bleeding. Usually they are bright red, okay? They are painless. So once again, painless vaginal bleeding that is bright red, and they have what? A soft or tender abdomen. The next, acute fatty liver may cause liver dysfunction but does not explain this client's severe hypertensive and urological findings. Okay, so for this question, remember you notice something, right? Every correct answers for this one are basically asking you what's the nursing diagnosis, and they can ask you, can you recognize the danger? And you know that severe blood pressure plus headache plus blurring of vision plus right upper quadrant pain equals emergency. So we need to make sure we're covering that, and then we need to make sure we have a good clinical judgment. So recognizing these symptoms, guys, of HELP syndrome is important. They are not gestational hypertension. They are not placenta abruptio. They are not placenta previa. There's no acute fatty liver. And this pattern, recognition wins on your NCLEX. So once again, remember, what are the clues again? Elevation of liver enzymes. They have a low platelet. They have a right upper quadrant pain. Visual disturbance. Think about HELP syndrome. So when you have those clues, they need help. So remember, HELP syndrome. right? So remember, they're not acute fatty liver, they're not placenta previa, they're not gestational hypertension. So HELP hurts the liver and they lower the platelets. So remember our mnemonics. It will ring a bell when you're testing, and make sure that you guys are able to recognize that. So once again, start with your head, start with your eyes, start with your liver, and start with your blood pressure. So remember, HELLP. Okay? You need help. And if you need help, we're here for you. Great job. All right. The client suddenly states, my headache is getting so much worse or getting much worse. Which condition is the nurse priority concern? So is it letter A, eclamptic seizure? Letter B, is this postpartum hemorrhage? Is it letter C, is this umbilical cord prolapse? Or is it letter D, amniotic fluid embolism? Remember, an emboli is a traveling clot, right? Emboli is a traveling clot. So is it alpha, beta, Charlie, or delta? So once again, the client suddenly states, my headache is getting so much worse. Which complication is the nurse priority concern? All right, so remember, now something changes. The headache suddenly gets worse. Need to take a pause, right? What complication immediately comes to your mind? Not tomorrow, not later, right now. So, what is your answer, guys? This patient is about to had a seizure. So, once again, this patient is about to had a seizure. Okay, alpha, beta, Charlie, or delta. And we know that in NCLEX, it's a highest priority to recognize this, particularly if you're on preeclampsia leading to eclampsia. So once again, that's why it's called preeclampsia leading towards eclampsia. So if you follow the next generation format, they're gonna give you one scenario, and then sometimes the question is back to back. They're gonna give you a couple of scenarios that is geared towards eclampsia. So when a patient has eclampsia, think about a worsening headache as your keyword. They have severe range of hypertension. Of course, their reflex is so active, hyperreflexia. They have a visual disturbances and an escalating central nervous irritability. And the client is at risk for a seizure. So never ever leave the patient alone. So if they tell you leave the patient alone, that's a bad intervention. Stay with your client, protect their head, make sure that the side rails are padded, especially once they undergo seizure. The head is so much important, right? So one thing that we need to remember when we're testing for the exam is thinking about those keywords, right? Worsening headache, hyperreflexia, clonus, visual disturbance. These are all neurological warning signs. We have to lock it in. Headache before seizure. Always think ahead. So one thing that we need to remember is about safety for your patient. So once again, this is your eclampsia or eclamptic seizure. So once again, eclampsia, preeclampsia plus seizure is called your eclampsia. So we're looking at a severe form of preeclampsia. We're looking at the symptoms, right? Remember, we talk about the triad symptoms of preeclampsia. You have your hypertension, edema, and proteinuria. HEP, hep hep hooray. So what is hep hep hooray? Hypertension, edema, proteinuria. And now they had a seizure, and that qualifies them for eclampsia. So this is emergency. Make sure we're doing about a thorough assessment for your patient, making sure also that they are kept safe at all times. So this is not a postpartum hemorrhage. So remember, the client's still pregnant and has no heavy vaginal bleeding, and there's no postpartum uterine findings. This is not umbilical cord prolapse, right? There's no sudden fetal drop of the heart rate or fetal bradycardia. There's no variable deceleration and not a worsening maternal headache. So this is not an amniotic fluid embolism. Remember, if you have embolism, remember a traveling clot. They will usually tell you that they have respiratory distress, they have hypoxia, they have hypotension, and possible disseminated intravascular coagulation. So DIC is very important. You bleed and you clot, and you clot and you bleed out. So most of the patients that have DIC will definitely need to be in emergency situations and be in the operating room because we want to rule out where they're bleeding. So it must mean that they are needing some interventions that is geared towards management of shock. And as we'll know, the more we bleed, the more we lose body fluids. And if the body fluids are lost in the body, you have classical symptoms of hypotension, oliguria, tachycardia, and tachypnea. And oliguria. So HOTT. Drop it like it's hot. Drop it like it's hot. Hypotension, oliguria, tachycardia, tachypnea. Once again, drop it like it's hot. Hypotension, oliguria, tachycardia, tachypnea. HOTT. So remember that. Okay? Next. So we're talking about select all the reply questions too. Okay. So the provider prescribes magnesium sulfate. Which nursing actions are appropriate? We need to select all the reply. Letter A, maintain a seizure precautions. Letter B, assess respiratory rate regularly. Letter C, do we monitor the deep tendon reflexes? Letter D, do we keep the calcium gluconate readily available? Letter E, do we restrict assessment of urinary output once per shift? Letter F, do we use an infusion pump to administer the medication? Or letter G, do we encourage the client to ambulate independently? Or letter H, do we monitor the fetal heart rate? Once again, if you're struggling with obstetrics question, this is very important, particularly when we talk about magnesium sulfate. And as we all know, magnesium sulfate toxicity is big on the NCLEX. This medication is one of the most tested medications on NCLEX. Every time you hear magnesium sulfate, I immediately think about respiration, reflexes, renal function, and of course, the calcium gluconate. Those four words alone answer half the magnesium questions on the NCLEX. So once again, every time I hear about magnesium sulfate, I immediately think about four things. Okay, what are those four things? Respiration, reflexes, renal function, and calcium gluconate. So remember those four. Okay, so remember, type in your answer into the chat box. Select all the replies can sometimes be challenging, but it's doable. You guys need to trust the process by eliminating letter A, is it true or false? Letter B, is it true or false? Letter C, is it true or false? Letter D, true or false? E, true or false? F, is it true or false? Letter G, is it true or false? Or letter H, is it true or false? That's how you should recognize those options. So once again, now the patient changes their respiratory rate, and that means that if it's magnesium sulfate toxicity, we're looking at BURP, blood pressure, urinary output, and patellar reflex. So once again, burp, blood pressure, urinary output, respiratory rate, and patellar reflex. Thank you, Charles. Thank you, Georgina. And how about the rest, guys? If you're listening in, if you're tuning in to this live, welcome once again. Welcome to our community. We started this community since 2015, and now we're rebuilding it. And I hope you guys support it too by tagging your friends that are taking the NCLEX really soon. So let's think about that one. Okay. So what is the answer? Thank you, Charles. Thank you, Georgina, for answering. And the answer is very good. Alpha, beta, Charlie, delta, and then letter F, and then letter H. So once again, think about this one. Magnesium sulfate is administered to prevent your seizure, but it can also cause respiratory and neuromuscular depression. So we talk about letter P, patellar reflex that is down. So blood pressure is down, urinary output is down, and then respiratory rate is down. So BURP, burp. If somebody's burping, BURP, it may mean that they have magnesium sulfate toxicity. So we have to make sure we maintain seizure precautions. We need to assess the respiratory rate and oxygenation of the patient, particularly if they have restlessness, anxiety, tachycardia, RAT. The early symptoms of hypoxia is RAT. What is RAT? Restlessness, anxiety, tachycardia. And then we need to monitor the deep tendon reflexes, measure the urinary output closely because magnesium is excreted by the kidneys. You need to make sure that there is calcium gluconate on the bedside because that will reverse the magnesium sulfate toxicity. And then we need to make sure to keep that in the infusion pump and continue fetal surveillance. So once again, the client should not ambulate independently because magnesium may cause weakness, being lethargic, and they could be very dizzy. So once again, make sure we do not ambulate them or else they're gonna be what? Or independently, they can fall. Remember that. And why the other answers are incorrect. Remember, checking the urine output only once per shift is incorrect because it must be monitored closely. As I have said, watch out for BURP. B, blood pressure. U, respiratory rate. R, U, urine output. Letter R, respiratory rate. Letter P, patellar reflex. So once again, BURP. So we're checking for lungs, we're checking for the legs, and we're also checking for the lavatory. So think about LLL. Mag checks LLL. So what is L? Lungs. L, legs. Letter L, lavatory. So once again, LLL. And then encourage independent ambulation can cause them to be at fall to be a fall incident risk. So think about that. Right now, we will take it into action. 2 hours after magnesium sulfate has started, the nurse obtains the following. The respiratory rate is 9 per minute. Oxygenations or oxygen saturation is 91%. Patellar reflex is absent. And then you have your urinary output that is 20 ml during the previous hour. And then the client is difficult to arouse. Which action should the nurse take first? So if I'm testing, I will look at the keywords. I will highlight 2 hours after mag sulfate administration. I will highlight also the respiratory rate. Now, when you're testing for the exam, right? Now the patient condition changes. Respiratory rate is 9. There is absent reflex. The patient is sleepy. There is a low urine output. What is happening? This isn't an uncontrolled preeclampsia anymore. This is big time magnesium sulfate toxicity. So what should we do? Letter A, increase the magnesium sulfate infusion. Letter B, stop the magnesium sulfate infusion. Remember, when there are two options that are opposite, one of them could be the right answer. Letter C, do we reposition the client and reassess in 30 minutes? Or letter D, do we administer an oral antihypertensive medication? Thank you, Georgina, for answering. Once again, for those who are testing, this is a safe space for you guys to practice. Because once you guys are testing for the actual NCLEX, it's not practice anymore. It's like make it or break it. You're determining if you're safe enough to practice as an entry level nurse. Okay? So Alpha, Beta, Charlie, or Delta. All right. Georgina, Charles, and the rest that are tuning in, past review, students, and also the pastors, thank you for your community support. Thank you for sending this to a lot of your friends and family. And we want to work closely with you guys to be successful, especially our kababayan Filipino American community. Mabuhay ang lahat ng nurse out here. Thank you for delivering the best care for our patients globally. Okay. So Alpha, Beta, Charlie, or Delta. And then please support Philippine Nurse Association, PNAA of America. So if you're not a member, please be a member of PNAA. There's so much resources out there. They had a conference right now in Colorado Springs, and thank you for all the leaders out there that are there in Colorado Springs. So Alpha, Beta, Charlie, or Delta? Okay, so what is your answer? This is big time. We need to make sure to remember what is your first action. Make sure we stop the infusion And our NCLEX principle for this is always stop what's causing the problem before doing anything else. So once again, our NCLEX principle for this one is always stop what's causing the problem before doing anything else. Then support the airway. We can call the provider. And of course, we can prepare the calcium gluconate. So what is your answer here? Very good. Two options that are opposite. So remember we talk about burp. What is burp? Letter B, blood pressure that is down. Letter U, urine output that is down. Letter R, respiratory that is down. And letter P, patellar reflex that is absent. So BURP. P as in Papa. And then we're talking about symptoms of oliguria, absent reflex, decreased level of consciousness. And we need to make sure we stop the infusion, support the airway and breathing. Remember ABC, airway, breathing, and circulation. We notify the provider, especially the interns or the residents that are catering to the patient, and prepare to administer calcium gluconate. So how do you remember that if there's a magnesium sulfate toxicity that you're gonna give a calcium gluconate? So just think about MS, magnesium sulfate, MS, Miss. So Miss Smith needs some caregiver. So what is caregiver? Calcium gluconate. So MSCG. So think about that one again. Magnesium sulfate toxicity. You gotta give a calcium gluconate as an antidote. So MSCG. Mrs. Smith needs a caregiver. Okay, that's how I remember when I'm testing for the actual NCLEX. All right, so think about MAGTOX RAU. We're looking for respiration. We're looking for absent reflex. Remember your deep tendon reflex, not the hammer that you buy in Home Depot, but it's your DTR or deep tendon reflex hammer. And then letter U stands for urine output that is down, or you call that oliguria. So know the mnemonics RAU, respiration, absent reflex, and urine output. Very good. Now, let's talk about umbilical cord prolapse. This is a classical NCLEX question, right? So let's read the question. A laboring client membrane ruptured spontaneously. The fetal heart rate immediately drops to 70 per minute during a vaginal examination. The nurse palpates the pulsating cord. Which action should the nurse take first? So you're looking for an affirmative answer. You're looking for priorities. Letter A, apply an internal fetal scalp. Do we do that? Letter B, do we place the client in a knee chest position and lift the presenting part? Do we do that? Letter C, do we administer oxytocin to strengthen the contraction? Do we do that? Or letter D, do we remove the hand from the vagina and prepare the client for ambulation? So think about your strategy for your NCLEX. So this is a classical NCLEX scenario. The membranes rupture, baby's heart rate crashes. You feel the cord. What do you think is happening to this patient? What will be the diagnosis? Umbilical cord prolapse, right? Question is, what's killing the baby? Is it cord compression? So what is our first job if it's a cord compression? Do we not relieve the pressure, or do we cause more injury to the patient, or do we relieve the pressure? So what's our first job? So type in your answer into the chat box, Alpha, Beta, Charlie, or Delta. Georgina, thank you. Georgina, where are you from again? Where are you watching us from? And Charles Dulay is from Philippines, I think. Yeah. University of Luzon. Shout out to all of you. Georgina is from New York. Oh, thank you for tuning in. So it's 10 p.m. almost at your time. Thank you. In California right now, it's almost 7 p.m. Right, 7 p.m. 2 more minutes. So thinking about the answer, Georgina answered letter B. How about the rest? Please type in your answer into the chat box. And we're all in this together. Remember, NCLEX is doable. So my wife is originally from New York, Georgina. And she followed love. She went here to California with me. All right. So what is your answer? All right. Let's reveal the answer. Georgina answered it. How about the rest? Still waiting. Remember, do not spend too long on one question. So, what is the difference between board certification versus the actual NCLEX? In terms of testing, you guys could not go on to the next question if you were not able to answer the question that is presented to your screen. So if you're taking your FNP, PsycNP, AGNP, or any specialty examination or board certification, you're able to flag them up. So it's different when you're testing for the NCLEX. You need to answer what is the question presented before you can move on to the next one. All right. So what is your answer? All right. Georgina, did you get it right? And for the rest of passers out here, did you get it right? Very good. So placing the client in a knee chest position is very important. So what is our first intervention? Remember thinking about the most important thing that we need to remember is knee chest position. Lift the presenting part and keep your hand there or prepare for emergency birth. Never remove your hand, right? So think about this one. The nurse must immediately relieve the pressure on the umbilical cord to restore fetal oxygenation while preparing for emergency birth. Our priority is to relieve fetal hypoxia from happening because what's going to happen, there could be complications. And we know that the oxygen can only surpass at least 2 minutes without oxygen, right? Beyond that, there could be irreversible brain damage, and that's one thing that we need to remember. So they could have cerebral palsy complications, or they could have oxygenation issues. So we need to make sure that they don't have fetal hypoxia. So remember, our past mnemonic is cord. If they come off the cord, make sure when the cord prolapses, time is very critical. Letter O, get the presenting part of the cord and elevate the head. Remember that, okay? Letter R, rush them right away to emergency section or emergency delivery. And letter D stands for deliver them quickly and safely. So letter A, they do not relieve cord compression, so they're incorrect. Letter C, stronger contractions would increase cord compression. And letter D stands that the nurse should keep the hand in place to elevate the presenting part. And that means that those are things that are incorrect. All right, so think about that one. Shout out to you, Georgina from New York. Got it correct. And for the rest, I hope you guys are learning plan this from this platform and you guys are the next one to pass your board. So once again, you're gonna be the next NCLEX next generation passer. Okay. Once again, you're gonna pass the boards, you're gonna practice confidently and ready to assume your first job as a nurse. And you guys are so much needed right now, and we need more nurses globally. Okay, so let's look at this next particular question. A laboring client at 40 weeks is receiving oxytocin. The fetal monitor shows that the baseline of fetal heart rate is 170 per minute. There is recurrent late decelerations and there is minimal variability. There is six contractions in 10 minutes. So which action should the nurse take first? Here you go again. They love to ask this question, right? What should you do first? So once again, letter A, increase the oxytocin infusion. Letter B, stop the oxytocin infusion. Letter C, perform a vaginal examination. We do this or not? Letter D, do we encourage the client to begin pushing? So remember, if you are unsure of your answer, Georgina, you need to go back again to the question. So reread the question one more time, right? Remember the song of Britney Spears? Hit me, baby, one more time. The same thing when you're taking your NCLEX. You gotta read the question twice if you have to, because sometimes we tend to over analyze or we tend to fall into the trap like asking, what if there's no doctor? What if there's no medication? What if? Remove your what if when you're taking your exam. It's not helpful when you're testing for your NCLEX. All right, letter A, B, C, or D. Thank you, Charles. Thank you, Georgina. You got this, everyone. So this particular is fetal heart rate safety. Okay. So what will be our first intervention? Remember, priority. First thing first. We're looking into this question as the highest priority or the first action. So they could term it like, what is your first priority action? What is your or first initial um, assessment is very important when we do this. If there's an incomplete assessment, we do further an assessment unless it's emergency situation. Okay, so follow your adpi. Correct answer is very good, Charles, and very good, Georgina. Okay, this is a typical NCLEX scenario. Remember, thinking about your patient that has this particular criteria. First intervention will be to stop the oxytocin. Then after that, I will put the patient to the left side. I will increase the IV fluids. Okay, and of course, we have to make sure we have to assess the mom all the time. Then call the doctor. Then think about oxygen before contractions. Okay. So thinking about that one, make sure guys remember to stop the oxytocin infusion. So this is the typical scenario that you can do. Right? Oxytocin should be stopped immediately. Reposition the client laterally, left lateral position. Remember Beyonce, to the left. And then increase the primary IV fluid as prescribed and then assess maternal blood pressure and oxygenation and notify the provider. And then administer a tocolytic if prescribed, and increasing oxytocin will worsen the uteroplacental perfusion. So, what is our strategy here? When two options are negating each other, one is a yin, one is a yang, or one is black, the other one is white. So, think about that one, right? Negating each other, alpha or beta, like the yin yang, and thinking about opposition needs to we need to make sure we do your contrasting strategies. Okay, so once again, do your contrast strategies, the power of negation. Okay, and think about late. Remember, if there's placental insufficiency, late deceleration suggests uteroplacental insufficiency. So thinking about that one, right? So if the patient is having a placental issues, that is a big problem. So think about that one. Uteroplacental insufficiency is late deceleration. Very good. Now, a client at 32 weeks arrived at sudden, painless, bright red vaginal bleeding, and we call this placenta previa is suspected. Which nursing actions are appropriate? Select all that apply. Letter A, do we assess maternal vital signs? Letter B, do we apply an external fetal monitor? Letter C, do we perform a digital vaginal examination? Or letter D, establish a large bore IV access? Letter E, do we quantify vaginal blood loss? Letter F, do we prepare blood specimens for laboratory testing and type and cross match? Or letter G, do we encourage the client to walk to determine whether bleeding increases? So this is very much particularly important for your exam. This is probably the easiest comparison on NCLEX, right? So think about placenta previa. It's given already on the question. It is painless. It's bright red. No vaginal exam. So repeat after me. No digital exam. Once again, no vaginal exam for placenta previa. We're making it worse. So type in your answer into the chat box. So what are we aiming for with this particular patient, guys? Okay. Georgina and Charles and the rest that are tuning in to this Facebook, Instagram, LinkedIn, YouTube Live. So please make sure to follow our different social media platforms. We also are live right now in LinkedIn. So for those who are tuning in at LinkedIn, hello everyone. Hello future nurses, and hello for all those that are tuning in worldwide. A, B, D, and E. Georgina says A, B, D, and E. How about the rest? Right. So think about your patient, right? They have placenta previa once again, painless vaginal bleeding, and they're bright red. So everything we do is aimed at preventing hemorrhage. So what do? We need to make sure we answer it correctly. We need to assess the mom, monitor the baby. Large IV is necessary. Blood should be available, and we always need to protect circulation. Okay, so think about this one. Placenta previa, once again, is painless, bright red vaginal bleeding, and they can include maternal and fetal assessment. So, one thing that we need to remember is IV access and preparation for possible transfusion and emergency birth. Okay, digital vaginal examination is contraindicated. Why? Because it can disrupt the placenta and may cause a catastrophic hemorrhage. So that's the reason why alpha, beta, delta, echo, and France are all the correct answers. So once again, A, B, D, E, and letter F. So once again, A, B, D, E, F. And thinking about catastrophic bleeding. So previa, once again, it's painless. Prevent vaginal inspection. So placenta previa will cause you to have a painless vaginal bleeding. Do not perform a vaginal exam, making it worse. It's painless. Once again, it's bright red. Do not do any vaginal inspection. Ultrasound first will be your priority, okay? So protect the mom and the baby. Letter G, we don't want to walk the patient because that can increase risk for bleeding and delay stabilization. And digital vaginal exam will cause you to have placental disruption and cause severe hemorrhage on the patient. Remember, you're making it worse. Very good. Once again, almost there, guys. Now, a patient on that has placenta abruption or abruptia placenta. So remember, your abruptia placenta. This is a typical client at 34 weeks of gestation. Reports sudden severe abdominal pain, and the nurse notes dark red vaginal bleeding and a firm board-like uterus. So let's dissect them together. Placenta previa, they're bright red and they're painless and they have soft abdomen. Abruptia placenta is the opposite. So I will master one over the other. So if I know placenta previa, it's just the opposite of abruptia placenta, which is board-like abdomen, dark red bleeding, and painful. Now, which condition should the nurse suspect? Letter A, placenta previa. Letter B, placental abruption. Letter C, uterine atony. And letter D, cervical insufficiency. Type in your answer into the chat box. Now, let's compare. Remember, previa is painless. Abruptio is painful. Rigid uterus, dark bleeding is abruptia placenta. And the patient is usually unstable until proven otherwise that this is a particular emergency situation that we need to cater to. And when there are two options that are opposite, letter A and letter B, they're opposite, and one of them could be the correct answer. Okay, Georgina, Charles, and the rest, University of Lausanne, College of Nursing, please make sure to participate into the chat box, and that's why we're here for you. Good morning over there. All right. Thank you, Charles. Thank you, Georgina, and the rest that are tuning in here. Please make sure to like, subscribe, and follow our past review center social media. We're going on live again, so I think Monday and Friday, Tuesday for your NCLEX, basically. We're adding more classes to you guys, okay? So stay tuned. So the answer is placental abruption or abruptial placenta. So thinking about dark red, they are painful and they have a firm or rigid uterus. The other one is soft, the other one is painless, and the other one is bright red. So now you remember one over the other. So do the process of negation or the process of opposite. So once again, abruption, abrupt, there's pain. So thinking about abrupt, there's pain, there's dark red bleeding, and the uterus is usually firm, tender, and they can be also hypertonic. And the main problem is the risk for the fetus, and it usually requires immediate attention. So remember your uterine atony, they have soft and buggy uterus. They're not cervical insufficiency. This usually causes painless cervical dilatation. So once again, make sure guys to remember that. Okay. So OB. Next, we have your postpartum laceration. 1 hour after a vaginal birth, A client has continuous bright red bleeding. The fundus is firm, midline, and at the level of the umbilicus. Which cause of bleeding is most likely? Letter A, uterine atony. Letter B, retained placental tissue. Letter C, genital tract laceration. Or letter D, bladder distension. Okay. So remember, what is your keyword here? They have a bright red bleeding, and then the fundus is firm. They are in the midline and at the level of the umbilicus. So what are we thinking here? Pain changes everything, right? Pain, once again, changes everything. Georgina answered letter B. Oh, okay. So what do you think is the answer here? Postpartum laceration, and this could be very good. This could be your genital tract laceration. Okay. So here's a NCLEX favorite. So the patient is bleeding, the uterus is firm, and if the uterus is firm, it is not usually uterine atony. So where's the bleeding coming from? It must be from a laceration. So think about that one. Continued bright red vaginal bleeding. They have a well contracted uterus. They suggest cervical or vaginal or perineal laceration. Okay. So remember, it's not uterine atony. Your keyword for uterine atony is soft, boggy uterus. It's not retained tissue because what's going to happen if there's retained tissue, the uterus often usually will prevents it from contracting firmly. So it could be um, incorrect statement. Letter D, bladder distension. They displace the uterus and contributes to uterine atony. So think about that one. They have a firm fundus. They have a flowing blood. Find the results. Make sure to check the vagina, cervical, perineum, and laceration. And laceration is the likely cause. So when there's firm fundus, there's flowing of blood, find the laceration. Very good. Lock it in. All right. I think we did 10 questions for today. Make sure, guys, for this particular scenario, assessment really matters. Don't just memorize and interpret, but interpret. Firm uterus equals look for somewhere else. So for those who are tuning in right now, we will review the lock-in pearls for today. So if you have a severe headache plus blurring of vision, they equal seizure risk. We talk about magnesium, we talk about BURP, blood pressure, urinary output, respiratory rate, and patellar reflex that is down. Think about respiration, reflex, urinary output, calcium gluconate. When there's cord prolapse, we talk about this. Lift the baby off the cord. When there's oxytocin and now it's causing tachysystole, stop it. Remember the song of Spice Girls, stop right now. Thank you very much. Stop the oxytocin. When there's tachysystole, stop it. Placenta previa, never perform a digital vaginal exam. When there's placental abruption, painful rigid uterus, firm uterus plus bleeding, think about laceration. So if you remember these patterns in your NCLEX and you have mastered them, these are highest yield OB questions on the NCLEX. Thank you for joining me on the NCLEX Lock It In Live today. And if this session helped you, like, share, subscribe, and invite a classmate who's preparing for the actual NCLEX. And always remember you have to study smart, think about safety, trust your clinical judgment, and most importantly, lock it in so you can pass it. So our upcoming classes will be July 21 will be your pediatrics, and July 28 will be your advanced medical surgical nursing. And then we are live 3 p.m. at Hawaii time, 6 p.m. Pacific time, 7 p.m. Mountain, 8 p.m. Central, 9 p.m. Eastern. Those are timeline that we need to make sure you guys tune in. Once again, save the date for those two particular content areas. And you can register the QR code. But if you're in the Philippines, mabuhay po kayo. Salamat po, especially University of Luzon, to all the faculties out there. And also the dean, the Dr. Jordan Lego. Woohoo! Salamat po sa trust with Past Review Center to do this collaboration with me. And then also 9 o'clock Philippine Standard Time. So once again, those are the high yield thing that we need to remember. And then we have a very important announcement, mid-month motivation, what to do when you feel behind. For those who are psych NPs guys, please don't forget to tune in to Facebook, YouTube, LinkedIn, Instagram, for all those who that are looking for core people or looking for a community and you just pass the boards or you're about to enter psych NP program, we're here for you. So once again, July 17, please save the date and we'll definitely gonna see you there. And then for those who are actively engaged, please make sure to scan the QR code for the evaluation form. So kindly take a few minutes to complete our evaluation form so we can continue improving our program and creating sessions that actually supports your journey. And your feedback means a lot to us. And as an educator and exam strategist, we're here for you. Okay. So once again, our website is fully launched. Woohoo! Salamat po. www.passnp.com. So once again, don't forget www.passnp.com, or you guys can scan the QR code that you're seeing right now on the screen. Sign up now and access it for free. So free po siya mga kababayan. So sa Philam community, wherever you are, either you're outside United States and you're preparing for the NCLEX, NLE, or whatever exam that you guys can benefit from our question banks. And these are prepared by nurse educators like me and my team that are really working hard to better service you guys and the community. So maraming salamat po. Please make sure to go to our newest website. And for those who are legacy students, you guys are more than welcome to click on the link that is provided on the screen and then create an account so you guys can access our new and old website. And if you have questions, please feel free to reach out to our support system, which is by email or by a call. And we'll more than welcome to answer you within 24 hours. All right. And once again, follow us in Facebook, Instagram, leave a review in the Google and Facebook. And let's create a community together. So, maraming salamat po for those who are interested to be part of our community. We have Psych NP Review. That is our pilot class, and we're so proud of the passing rate. Especially congratulations to Deepika Goyal for passing both AANP and ANCC recently. And then we have FNP, AGNP review for both ANCC and ANP. We have NCLEX Next Generation RN and NCLEX Next Generation LPN review, which we give you like a 10 practice questions today, and that's how we teach you guys how to remember things. Then you have your live masterclass, on-demand review classes. Yes, Georgina, our NCLEX review is in the website too. And then on-demand Flix crash course. So it's like a live stream. So we have different videos out there for with our seasoned educators, me, Laddie, and Professor Jerome, and other faculty that are doing the review. And then question banks, very important. Our one-on-one last-minute preparation review, and we are a CEU provider by the BRN California and BBNPT under the process of ANCC, hopefully to be released this year. IV therapy and blood withdrawal course for LVN certification. First aid training, guys. So very important when we do our American Heart Association or Red Cross or your Heart Savers. And then BLS, basic life support, ACLS, advanced cardiac life support, your pediatric advanced life support, ASLS, acute stroke life support. And we'll see you at the next live class, guys. So please utilize Pass Review 10, which is our coupon code discount for 10% off. Okay, who doesn't like 10% off? So this why choose pass over other review center. We are expert led courses. We are up to date with our content. We have a high pass rates. So proud of our passing rate this quarter. We are flexible and self-paced, and the support the community is providing is immense. And your success is our mission. Once again, you pass the exam and you practice confidently. So you're not just getting the review from us, but the mentorship, the support, and the feeling that you belong and the feeling that you are a part of family and part of the community makes us stand out with other review centers. So once again, I'm Pedro Morante. Maraming salamat po sa lahat po ng kababayan ko. Thank you so much for your undying support. To my wife and to my kids, thank you for allowing me to do this. And to all the patients that I serve and to all my kababayans, you are the reason and my wife why we're doing this. And I hope to serve you better and see you in the next live. Maraming salamat. Bye-bye. Ending this live stream.